Hi everyone, I'm Dr. Sanil Rege, consultant psychiatrist. Today I'll be taking you through the critical appraisal of a recent paper that looked at the relationship between ADHD medication and the risk of cardiovascular diseases. Now, this was a case control study, a nested case control study specifically. Now, this critical appraisal will be extremely useful for candidates that are sitting their RANZCP or MRC Psych critical appraisal exams, or for any other exams where critical appraisal is examined. It's also really useful for those who want to learn more about research and statistics and how to appraise a clinical study. Now, for those of you who want to learn this in a lot more detail, particularly if you're preparing for the exams, don't forget to check out ranzcpexams.psychscene.com, where we have a comprehensive critical appraisal course that lasts for more than 7 hours, which also consists of quizzes, and I take you through actual real-life papers and how to appraise them. And we cover all the studies and the methodology in a lot more detail. So don't forget to check out ranzcpexams.psychscene.com. Besides research and statistics, understanding of numbers becomes very important in real life as well. Charlie Munger, who passed away 2 days before this video, said, "Without numerical fluency, you're like a one-legged man in an ass-kicking contest." Now, of course, a very crude statement, but Charlie Munger wasn't someone who minced his words. It hits the point home. Numbers and understanding of probability is extremely important for all of us to help in making appropriate decisions in life. So with that in mind, let's jump in and check out the study. Now, this is the paper. You can go through this in your own time. As you can see, it says attention deficit hyperactivity disorder medications and the long-term risk of cardiovascular diseases. So what we know is this is a case control study. And let's take a broad perspective about what researchers are actually trying to do when they're conducting studies. You see, in research, what we're trying to do is to try to establish an association or understand the association between two variables. And we've got A, which is the exposure variable, or also known as the independent variable, which in this case will be attention deficit hyperactivity disorder medications, because we're asking the question, do these medications increase the risk of the outcome, which is cardiovascular diseases? The outcome here is B. So as researchers are trying to establish the association between A and B, we know that there are several other variables that start playing a part here that can affect this relationship. So what we have is things like confounders. For example, if there's someone with substance use, you see a confounder is a variable that is both associated with the exposure. So we know that substance use is associated with ADHD or ADHD and medication, because individuals with substance use are more likely to have ADHD and they might be on medication for treatment. But we also know that substance use increases the risk of cardiovascular disease, the outcome. So this is a confounder that is in a triangular relationship with the exposure and outcome. And you can imagine so many different confounders would be playing a part. So whenever we're designing a harm or etiology study, such as a case control study or a cohort study, we've got to ensure that we minimize the influence of confounders. This is known as adjustment. And we'll see what the researchers have done is they have done what's known as a regression analysis that minimizes the influence of this confounder so that we can get a better understanding of the association. Similarly, what we've got here is we've got, if the methodology is not appropriate, then we end up with a number of biases, selection bias, measurement bias, etc. And that can also influence the association. So the aim of research is to examine the association between A and B whilst adjusting for confounders and ensuring that biases are minimized. So that's the broad aim of research here. Now, knowing that, let's look at the steps in a case control study.
Hi everyone, welcome to Psychiatry Simplified, the world's leading psychiatry channel for all things psychiatry and neuroscience related. We combine years of clinical experience with academic knowledge with the aim of helping you understand the brain and the mind-body connection better. I'm Sanil Rege, consultant psychiatrist, founder of PsychScene and Vita Healthcare. If you're new to this channel, be sure to like, subscribe, and turn on that notification bell. So let's get started.
So firstly, we've got to select cases and controls. Now, the key aspect of a case control study is that we begin from the outcome. So we begin from B, which in this case was ADHD and cardiovascular disease. We'll see later that the cohort, they've nested this case control study within a cohort. And what's that cohort? Individuals with ADHD. What they did was to find individuals with ADHD and cardiovascular disease, which they labeled as cases, and those without cardiovascular disease became the controls. So when that happens, it's important for us to recognize that they've begun from the outcome. And what they'll do is now try to identify the exposure. So what are the questions at this stage? Firstly, are cases clearly defined? How did they identify individuals with ADHD and cardiovascular disease? So we'll see they went through registers, diagnoses made by medical professionals. Were controls representative of the population from which cases were selected? So one of the things here is, are we sure that controls did not have cardiovascular disease? And that's a big question mark that comes up in this particular study. Then we also need to look at, were cases and controls similar in all aspects except for the outcome, which basically means cases, the only difference between cases and controls is the cardiovascular disease. So they should not be statistically significantly different in all other aspects except for the cardiovascular disease. And that's an important point. But also you can imagine it's so difficult selecting a control group with characteristics very, very similar to the cases, except that they don't have the disease or the outcome in question. And that's tough. And Sackett, who is widely known as the father of evidence-based medicine, said that he would trust only 6 people to do a good case control study because control group selection is so difficult. They're notorious for spurious associations. And finally, can confounders be managed at this stage? We'll see in the study they did what's known as matching for some confounders such as age, sex, etc. And that minimizes selection bias. Next, you've got to assess for exposure. What's the exposure in this case? This was the A. And exposure here is medication, ADHD medication. And note, this is not just stimulants, this is medication. We'll see stimulants and non-stimulants. And here we've got to define the exposure properly as well. And we've got to ensure, how was recall bias minimized? Recall bias is a real problem in case control study, because you see what happens is when we identify an outcome or individuals that are cases and controls, we usually ask them whether they've been exposed to the particular exposure. And what happens here is a recall bias, a search for meaning bias, where individuals with the disease are more likely to search in their memory for the particular exposure in question. So this creates a recall bias. And you can see that the direction is actually outcome to exposure, not forward. So we'll see later from a Bradford-Hill criterion of temporality, that's not fulfilled either. And there are 2 other points as well we've got to look at, because this minimizes then information bias, also known as measurement bias. So the investigators that are assessing for that exposure also need to be blind to outcome status. So they shouldn't know who has cardiovascular disease, who doesn't have cardiovascular disease. They should independently be assessing for exposure. Then we've got to adjust for confounders. As I mentioned, those confounders can influence the relationship between ADHD, cardiovascular disease, and of course the exposure to medication. So here we'll see in the study, they did what's known as a regression analysis. We have a crude odds ratio, and then after adjustment, we get an adjusted odds ratio. And that's when we can interpret it. And almost always you'll see that the adjusted odds ratio is changed because it sort of removes the influence of the confounders. And that minimizes confounding bias. And when that's done, we're then able to calculate an odds ratio. And here, very importantly, there are 2 aspects. One, clinical significance, which is the odds ratio number, which gives us the strength of association, versus the p-values of confidence intervals, which gives us the statistical significance. Now, we won't go too much into detail of the p-value interpretation or confidence interval interpretation, because that is a separate topic. You can learn more on the online course. But here what becomes very important is to interpret this properly. And this is where often the interpretation of odds ratio is done incorrectly, in the incorrect direction. We'll see that in a bit. All right, so now that we've gone through the basics of appraising case control studies, let's look at the actual study. So the first thing we want to look at is how did they identify the cases, the controls, and then the exposure. We know this is a nested case control study specifically, which means that this case control study is nested within an existing cohort. And that cohort consists of individuals in Sweden aged 6 to 64 years who received an incident diagnosis of ADHD or ADHD medication dispensation between this time period. Now, the data on ADHD and cardiovascular disease diagnoses, which is the outcome, and ADHD medication, which is the exposure, dispensation were obtained from the Swedish National Inpatient Register and Swedish Prescribed Drug Register. The question for me is it possible that there are some individuals that have been missed, individuals that have had a predisposition to cardiovascular disease or a cardiovascular event, but are not recorded on this register? That's definitely possible. And that results in an under-ascertainment. So whenever there is a selection bias of this form, where that the cases are not the true cases, some are missed, that results in a change in the final odds ratio, which indicates also the change in the risk and how we evaluate this association. Cases included individuals with ADHD and an incident cardiovascular disease diagnosis, and they've outlined all of these different cardiovascular diseases. Then they go on to select up to 5 controls, and that's a good thing because 5 controls to every case reduces the confounding bias, increases power, better precision of the study. Next, they talk about controls. Now, controls were eligible for inclusion if they were alive, living in Sweden, and free of cardiovascular disease at the time. The key here is, do we know that controls were truly free of cardiovascular disease? No predisposition, no risk for cardiovascular disease. Any of these things influence the final odds. So if individuals are missed and there are controls that actually have cardiovascular disease, then they should actually be in the case group. And the authors acknowledge this. They say, our approach for identification of patients with cardiovascular disease was based on recorded diagnoses, and there could be under-ascertainment of cardiovascular diagnoses in the registers used. So under-ascertainment brings in a selection bias. And whenever cases, controls, the overall incidence is lower or higher, that can result in odds changing, either higher or lower. So missing cases or over-inclusion of cases affects the final odds. Then they talk about exposure. The main exposure was cumulative duration of ADHD medication use. The important thing here is all ADHD medication, stimulants as well as non-stimulants. Now that we know this, how do we interpret an odds ratio? The crucial aspect to remember is that we began the sample selection from the outcome of the disease, which was ADHD and cardiovascular disease diagnoses. And then we're examining for exposure. Therefore, the odds ratio is the ratio of odds of exposure amongst cases versus controls, not the increased risk of cardiovascular disease amongst exposed individuals, because the direction in which we have designed the study is starting off from outcome, the disease, and then looking at whether these individuals have been exposed to ADHD medication in this case. Therefore, odds ratio is the ratio of odds of exposure in cases versus controls. So now let's look at interpreting the graph. What we can see here is we can see the cumulative duration of ADHD medication exposure, and then this is the odds of cardiovascular disease, which is the outcome. And what they've done is they've divided this into the full sample, then group age less than 25 years, and the group age greater than 25 years. What I'm interested in is the adjusted odds ratio, not necessarily the crude odds ratio. Adjusted odds ratio is where the confounders are adjusted. So the influence of confounders is taken out of the equation to give an adjusted odds ratio. And here they've outlined all these confounders that they've adjusted for: somatic comorbidities, psychiatric comorbidities. Why? Because these comorbidities influence the odds of developing cardiovascular disease and also the odds of being exposed to ADHD medication. So how do we interpret this? So first thing I look at is the value of no effect here, adjusted odds ratio. 1 basically means that the risk in cases is the same as the risk in controls. It's exactly equal. When an odds ratio is greater than 1, it's telling me an increased risk. If it's lower than 1, it's telling me a decreased risk or odds. So let's look at specifically how to interpret this. If I were to take greater than 5 years, and what we can see here is that the odds is 1.23. That's telling me there is an increased odds of cardiovascular disease. Now, in this particular paper, what they've done is they've interpreted this as an increased odds of cardiovascular disease, as you can see here. But remember, we began the sample selection from the outcome of the disease in question, and then we're examining for exposure. We also saw that odds ratio is the odds of exposure in cases versus controls. Therefore, this particular odds of 1.23, how do I interpret this? We can see it does not cross the line of no effect, so that's telling me this result is statistically significant, but we're going to delve into the clinical significance of 1.23. This tells me that individuals with ADHD and cardiovascular disease are 1.23 times more likely to be exposed to ADHD medication for more than 5 years. Note the direction of inference. Individuals with ADHD and cardiovascular disease are 1.23 times more likely to be exposed or take ADHD medication for greater than 5 years. And this reverse causality aspect is really important. Why? Because we know that individuals with cardiovascular disease and ADHD are more likely to have cerebrovascular involvement as well, because cardiovascular disease is a vascular risk factor. And vascular involvement of the brain is associated with greater executive dysfunction, a greater severity of symptoms of cognitive dysfunction, hyperactivity, impulsivity, and therefore these people are more likely to need ADHD medication as well. So this is a crucial component because that raises the question, is ADHD an independent risk factor as well for cardiovascular disease or cerebrovascular disease? And we'll see that in a bit. So this is a crucial point to take into account. Moving forward, when we look at this table, what they've done is looked at specific cardiovascular diseases, arrhythmias, arterial disease, hypertension, cerebrovascular disease. And when I'm looking at the adjusted odds ratio broadly, you can see if I take arrhythmias, here what I'm seeing is this is a reduced odds, slightly increased odds of 4%. Reduced, reduced, reduced. Now they're not statistically significant because they cross the value of no effect. But this is sort of giving me an inconsistent increase, decrease. That's telling me there is no dose-response relationship. And that's important because you see, one of the key Bradford-Hill criterion for causality is as the exposure increases, the odds of the risk also increases. And there is only one place where that happens, and it's for hypertension. As individuals go from 0 to greater than 5 years of exposure to ADHD medication, you can see that there is an increase in odds here, 1.06 to 1.80. And it's a sort of, even here, 1.34, it drops down, but then goes to 1.72. You can sort of give it a bit of leeway and say there is a dose-response relationship. The strongest association, which is the strongest odds, is actually 1.80 in the entire table, which is a very mild association. In psychiatry, anything greater than 10 is considered a strong association. So 1.80, how do we interpret this? And it's statistically significant, as you can see. The correct way of interpretation is individuals with ADHD and hypertension are 1.8 times more likely to be exposed to ADHD medication for more than 5 years. Note again the direction. Individuals with ADHD and hypertension are more likely to be taking ADHD medication. And again, that's not surprising because hypertension is a vascular risk factor. It's associated with white matter hyperintensities. White matter hyperintensities is associated with executive dysfunction. It's a marker of cognitive aging. And therefore, these individuals are more likely to need dopaminergic, noradrenergic agents because the prefrontal cortex, particularly when involved from a vascular perspective, D1 receptors and alpha-2A receptors play a part in the prefrontal cortex. And in order to improve prefrontal cortex functioning, that's exactly where stimulants come in to potentiate noradrenaline and dopamine to target those D1 and alpha-2A receptors. So you can see here, when we're evaluating a study, we not only look at the study as such, we also look at other data, which we'll come to in a bit, but we connect this to clinical practice. And at the same time, we take patient values into account, the risk-benefit analysis and their specific preferences. So if you look at this whole table, again, there's no real dose-response relationship anywhere. So broadly, what this is telling us is not that individuals who have taken ADHD medication have an increased risk of cardiovascular disease. What it's telling us, if at all, is that individuals with ADHD and cardiovascular disease are more likely to be exposed to ADHD medication, more likely to be taking ADHD medication. And this is known as confounding by indication or confounding by severity. What that means is individuals with a more severe illness because of cardiovascular disease are more likely to need ADHD medication. So the big question, is ADHD independently associated with cardiovascular disease or cerebrovascular disease? And if we look at a cohort study that was done, what this tells us is that there is an independent increased risk of cardiovascular disease and cerebrovascular disease with ADHD. And note, this is a cohort study. What a cohort study is, it begins from exposure and then moves towards outcome. So it begins from individuals with ADHD, some on medication, some not on medication. They're followed up to see whether they've actually developed the outcome in question. Or if it's done retrospectively, the direction is still from exposure to outcome. And now I can interpret this hazards ratio as an increased risk because the direction is from exposure to outcome. So what we can see here is there is double the risk of cardiovascular disease, of any cardiovascular disease in individuals with ADHD. Even after adjustment, this risk remains. Note, the strongest odds in the case-control study was for hypertension, 1.80. And there were a number of values that were reduced odds as well. So it was inconsistent. What we can see here is there is a consistently elevated risk across the board for ADHD and cardiovascular disease risk. The only place we can see that it's not statistically significant, still clinically significant, is this place. But every other place we can see that there is a consistently increased risk. And does it make sense? Does it make biological sense? Absolutely. ADHD is associated with inflammation. And we know that dopamine has anti-inflammatory properties, anti-neuroinflammatory properties, and therefore treating ADHD can reduce the risk of neuroinflammation or inflammation as well. And we see this in clinical practice when we find that allergies or inflammation or pain, etc., reduces when we adequately treat ADHD. Now, you might ask the question, well, this increased risk could be due to stimulants. What the researchers did was they excluded those being treated with stimulants. And note what happens here. There is still an increased risk even in those people where stimulants are excluded. And even after adjustment, this risk remains. It reduces, but it still remains. If we look at this 1.77, which is statistically significant, this tells me individuals with ADHD are 1.77 times more likely to have cardiovascular disease. So let's look at the Bradford-Hill criterion for causality. And the four most important ones that we focus on are strength of association, temporality, biological plausibility, and biological gradient, which is also known as dose-response relationship. And let's connect it to the case-control study and the cohort study that we saw. So firstly, strength of association is how large is the effect. And we saw that in the case-control study, there was an inconsistent effect. Reduced odds, increased odds. The strongest odds was for hypertension greater than 5 years of 1.80. So this is a mild association. Whilst when we saw the cohort study, there is a consistently elevated increased risk of cardiovascular disease. Of course, again, we saw mild associations. The next is temporality. Temporality is, does exposure truly precede the outcome? In case-control study, this temporality is not fulfilled because we begin from the outcome in question and then we examine for exposure. So the interpretation in the case-control study, let's say for hypertension, was individuals with ADHD and hypertension are 1.8 times more likely to be taking ADHD medication for more than 5 years. Whilst in the cohort study, we could say that individuals with ADHD have double the risk of cardiovascular disease because the temporality exposure preceded the outcome. Next, biological plausibility. This works both ways. Can stimulant use increase the risk of cardiovascular disease? Yes. On the other hand, there is reverse causality as well, which is, are individuals with ADHD and cardiovascular disease more likely to need ADHD medication? Yes. This is the confounding by severity, confounding by indication. Why? Because individuals with ADHD and cardiovascular disease are more likely to have vascular brain involvement and therefore a greater severity of executive dysfunction, impulsivity, hyperactivity, therefore needing ADHD medication. And finally, biological gradient. Biological gradient we could evaluate in the case-control study, and we saw there wasn't really a dose-response relationship that was really consistent. So therefore, when we're applying this to clinical practice, we've got to take the entire picture into account. We've also got to take into account that ADHD is an independent risk factor, and neuroscientifically, we know that individuals with ADHD have a greater risk of inflammatory disorders because dopamine plays a crucial part in neuroinflammation. So I hope that this gives you an understanding about how to appraise a case control study and some nuances about how to interpret odds ratios correctly so that we don't misinterpret the direction of causality, which becomes so important when we're applying those results to clinical practice. Once again, for those of you who want to delve into this fascinating subject and actually go through case studies, actually go through papers, because the best way of learning critical analysis and critical appraisal is to start off from papers, apply the methodology, and then learn the concepts. There's no better way of doing this. And if you want some guidance, don't forget to check out the CAP course on ranzcpexams.psychscene.com. Take care, everyone. Stay curious. See you next time. Bye-bye.